7 million abortions are conducted annually, and 50% of those estimated to be illegal. And maternal death due to complication from unsafe abortion ranges from somewhat about 8%. So this is very vital issue for discussion. And if we go with some statistic from Lancet, then 44% of the worldwide annual 227 million pregnancies are unintended, and out of those 56% end into abortion, 32% in an unplanned birth, 12% in miscarriage, and unsafe abortion causes almost 8 to 11% of global maternal death. So with these figures, and to have a safe abortion, not only safe to patient, but safe to service provider also. This MTP Act 1971 was enacted, and it was came into existence. But even with this MTP Act, there were so many litigation, writ petition before Honorable High Court and Supreme Court seeking permission to terminate pregnancy beyond 20 weeks of pregnancy, and mostly in cases of congenital anomalies or in rape victims. And at the time of discussion in Lok Sabha and Rajya Sabha, at the time of this amendment, these points were taken into consideration. And one more point was also taken into consideration, that with advanced medical technology, now it could be little safer to terminate pregnancy even beyond 20 weeks of pregnancy. So with these two aims, this amendment came into existence. And when this amendment was discussed in Lok Sabha, it was also discussed there are unavailability of qualified medical personnel to terminate pregnancy, particularly in rural India. And as far as one survey of All India Rural Health Statistic, which was happened in 2018 and 19, in rural area, there were 1,351 service provider, qualified service provider or gynecologist, we can say, and almost 4,002 places were vacant. So shortfall was almost 75%. And one more survey was also conducted by National Health and Family Survey. It was conducted in 2015 and 16, that only 53% of abortions are performed by registered medical practitioner or registered medical doctor, and balance are conducted either by nurse, either by auxiliary nurse midwife, either by DAI, by family members, or by self-medication. So with all this statistic and history, it is very vital subject for discussion, and how abortion services could be safer one, not to the patient only, but to the service providers also. So again, I congratulate OBGYN Society of Aurangabad for keeping this vital subject. Thank you very much for inviting me to share my views about the subject.
Thank you so much, sir, for joining us. Thank you so much.
Welcome.
Next, we have with us our very respectable. Thank you, sir. Next, we have with us our very respectable Dr. Sneha Bhuyar, ma'am. Ma'am is the Managing Director of Sukhakarta Hospital, Laparoscopy and Infertility Center, Yavatmal. She has over 5 years of teaching experience at VNGMC, Yavatmal. Ma'am has various awards and allocates in her kitty, including the National Individual Award by Foxy, Anandibai Joshi Award by the Government of India, and she had won various awards through Foxy for her social work and her healthcare work. Ma'am has held various official posts in Foxy as well as in YOGS. Ma'am was the organizing chairperson of around 4 conferences, including 2 in Pune. She has done various research, presented various research papers, and done research in breast and cervical cancer, also menopause. She has educated various doctors through more than 300 talks at national and international conferences and has written various articles. Ma'am, we are very pleased and obliged to have us with you today. A very warm welcome to you also.
Thank you. Thank you so much, Dr. Vaishali, for that very kind and generous introduction. A very good evening to all the esteemed guests and guests of honor, all the faculties, chairpersons, and all the attendees. Special thanks to Dr. Gurpreet and Aurangabad Society, and of course my mentor, Dr. Rajendra Singh Pardesi, and my younger brother, Dr. Ajay Mane. Thank you so much for having me here. First of all, I would like to congratulate Dr. Gurpreet and Aurangabad Society for having this program. You know, over the years, we have been talking about this abortion care right from the days when it was not even permitted, leave apart the question of liberalization. So initially when this act was passed, 1971, after that, there are so many amendments, and recently the amendment which all of us were waiting for. So I'm sure Dr. Gurpreet is going to discuss everything about this. And we have various stages of development of this aspect of this topic. Liberalization of abortions and safe and unsafe abortions, and of course comprehensive abortion care by NHM, National Health Mission, and now respectful abortion care by FOXY. So hearty congratulations, President FOXY, Dr. Shanta Kumari Madam, and the entire team for designing this program. And thank you so much, all of you, for inviting me here. Thank you once again. Over to you, Dr. Vaishal.
Thank you so much, ma'am. Next, we have with us respected Dr. Ajay Mane, sir. Sir has also taken his work to the state level, and we are very proud that he belongs to Aurangabad. He is the Vice President FOXY Elect 2024. He is the member of NIMC. He is a medical legal consultant and specially gives free of cost advice since around 18 years now. He was the official. Yes, sir.
We can skip that.
Yes, sir.
We are behind schedule. We can skip that. Thank you. Thank you very much. Vaishali, Gurpreet, Varay Madam, all Aurangabad Society, because this is my home society, and you have got every right to order me for anything. So I'm here. I'm very happy that I'm again active in webinar after 1 month rest. So good evening. And again Aurangabad has started taking good programs, and initially you have taken a good FOXY initiative. So it is a dream of FOXY, and this is a basic. Our aim is to provide good, as Patel sir and Snehate said, this is our basic duty to provide a good health facility to all women, and abortion care is also included in that, and everything is there. So I won't take much time. Thank you very much for inviting me here, and pranam to MC Patel sir, pranam to my sister Where ma'am, then Jyoti ma'am, and Neeraj bhai. Thank you very much.
Hello.
Vaishali, you are muted.
Sir, I'll start off with the first session because we are running out of time. Is my screen seen? Hello?
No.
No, not yet seen. Not yet seen.
Not yet seen.
Yes.
Just give me a second.
No, that CV was displayed by you only, no, Gurpreet?
Yes.
That was that time it was seen. Now.
Yes, that's. Yeah.
Just 1 second. Okay.
Yes. Now it is seen.
Yes.
Yeah. Make it a full screen.
Okay, sir. Is it full screen now? Okay.
Yes,
First
it's
and foremost, thank you so much, Vaishali Surase, Secretary, Aurangabad Obedience Society. And thank you so much, MC Patel, sir, for being here with us today as a guest. And also thank you so much, Ajay Mane, sir, and Sneha Bhuya, madam, and all the dignitaries. I also welcome Dr. Anjali Vare, madam, President, Aurangabad Obedience Society. And without wasting any time, I will get started. And now, with the Medical Termination of Pregnancy Amendment, MTP Amendment 2021, Respectful Abortion Care, this is a joint initiative of FOXI and the World Health Organization. This is has been initiated by the president of FOXI, Dr. Shanta Kumari Madam, and the sole purpose of this webinar is that each and every FOXIan should be aware of the latest MTP Amendment Act, and accordingly we are supposed to give services to our women. And with this act, India stands tall amongst other developed nations where comprehensive abortion care facilities are now available. So what is the objective of taking this session? The main motto of this session is for the dissemination of knowledge. The more we read any act, we get confused. So to clarify, we have taken up this session. And what are we going to know here? What are the new laws? MTP Act was there since 1971 when it was then later on amendments were made. We have been doing MTPs, but now we have got few more clauses in it. And now there is access, more access for the women. And here our sole motto is that whenever we are giving MTP care, though we have been doing this procedure day in and day out, but now with respect. It is in line with the respectful maternity care. So it is not just provision of the service, but the service has to be provided with respect, dignity, safety, and other parameters taking into account, as well as the law. So what are the new laws and what are the changes in the rules? The sole reason behind this amendment is taking into consideration the safety of women. The law was there initially also, but now here in this law, we are giving more emphasis on the safety of the women. There are so many women who go in for unsafe abortions, and this unsafe abortion is a leading cause of maternal mortality, morbidity, and hamper women and girls' full participation. So what does the statistics say? From the statistics, we are not going to get the broader view because many abortions are not reported. So whatever statistic we have got on that, what we have seen is 8% of maternal deaths per year are due to abortions, which is the third leading cause of MMR. Nearly 2 out of 3 of the abortions performed are deemed unsafe. Nearly half of the pregnancy-related deaths are in women and girls under 24 years. So taking all these into consideration, we have made the law has been amended. So what is happening that initially there were more women who were resorting to unsafe abortion because of the fear or whatever problems they had. Mostly in the peripheries where facilities were not available, they used to resort to unsafe abortion. And that led to increase in the deaths of women. So this is all these values are from taken from various sources, Ministry of Health and Family Welfare, and we have got these statistics. So what do we do now? When is abortion considered safe? So we have to keep in mind 3 things, 3 P's in fact. The process should be safe, the provider, and the place. The provider should be trained enough in performing abortion. The place should be safe enough to perform. It should be registered, certified, and then you consider it as safe abortion. So by the definition of WHO, safe abortion is when it is provided by a trained person and with appropriate method. So first trimester abortions, the method is different. For second trimester, it's different. So safety is of utmost importance, and these criteria are to be met. When these criteria are not met, then that is considered as unsafe. So Medical Termination of Pregnancy Amendment Act 2021, safe and comprehensive care mandated by law. So let's go into the salient features of the MTP Amendment Act 2021. We had the act. I've been telling you that we have been having the act. So why is the need? So here we have to increase the access so that more and more women can, take this safe abortion method. So in the previous act, what was it? Previous act, requirement of opinion of one provider for MTP up to 12 weeks, requirement of opinion of two provider for MTP for 12 to 20 weeks. But with the amendment, what they're saying is requirement for opinion of one registered medical practitioner for termination of pregnancy up to 20 weeks of gestation. So in a hospital, if you are the only person who has been doing MTPs until now till 12 weeks, now you can do it till 20 weeks. Only one provider is required. And requirement of opinion of two registered medical practitioners for the termination of pregnancy between 20 to 24 weeks of gestation. This was not there in the previous act. With the new act, we have got the provision of terminating the pregnancy up to 24 weeks, but we should have two registered medical practitioners. Now, even in the law, they have said who is a registered medical practitioner. Later on, we'll come to know what it includes. So what is the potential outcome of this amendment? Increase in the number of facilities, especially in the peripheries, PHCs, where the providers are less for the MTP. There, the access will increase. So the previous act, second point here is, in the salient features, MTP is permissible beyond 20 weeks only when it is immediately necessary to save the life of the pregnant woman. That was the only thing where we used to go beyond 20 weeks. But now with the amendment, 2021 amendment, what has happened? Here now we have increased the gestational age limit, enhanced the upper gestation limit from 20 to 24 weeks for special vulnerable categories of women. So here, now the access has been increased, more women can take part in it, because many times it happens that because of they're not aware of the menstrual cycle and they report late to the hospital, and then gestation growth increases, and then we say that now you can't go in for MTP. Now here with the new amendment act, we can do MTP up to 24 weeks, but we should have two medical registered medical practitioners. And it is not that everybody can access, only special vulnerable categories. Again, in the law, they have defined who are the special vulnerable categories of women whom we can provide this service. Further enhancement for birth defects not compatible with life on medical board consensus. So there are medical boards formed, and they can, give us opinion whether the pregnancy can be terminated or it cannot be terminated. So we will also discuss in details about the medical boards. So with this change in the act, what has happened is there is increased access for vulnerable women to safe and legal abortion services. Now, initially, what used to happen is we used to consider so many factors, whether married, unmarried, young girl, age we used to consider. Now, what the law says is we have to, cut down the bias. There should be no bias, and everybody should be given. We don't want any woman to die because of unsafe abortion. So the access to women, more so to the vulnerable women, has increased for safe and legal abortion. Okay. The previous act had a provision for termination of such pregnancy only up to 20 weeks. Now, with the amendment, upper gestation limit does not apply in cases of pregnancies with substantial fetal abnormalities diagnosed by a medical board. Now, here we talk about the medical board. Various states have formulated their own boards. Right now, there are 178 boards which are functioning. And wherever the boards are not there, FOXI is going to take initiative and the boards are going to be formed there. Now, with this, what is happening? There is increase in the access to safe and legal abortion services, who often seek service late beyond legal limit for termination of pregnancies with substantial fetal anomalies diagnosed late, thus reducing unsafe abortion and court cases. Now, in the previous act, the condition of failure of contraceptive was applicable for only married women or her husband. Now, with the amendment, what is happening is condition of failure of contraceptive is to be extended for any woman or her partner. So this will bring about increased access to safe and legal abortion for any woman, irrespective of marriage age, especially with upcoming changes in legal age of marriage, an important advancement for increasing access to safe abortion. So with the amendment, what the government is trying to do is that going to take care of women's safety first. Safety is of paramount importance. Not only safety, it has this abortion care covers also the dignity, respect. Everything has to be taken into consideration. We should not be judgmental. If a patient comes to us late in the gestation for termination of pregnancy. So these are the few important factors the government has taken into consideration. Now, continuing with the same amendment, the previous act, the Medical Termination of Pregnancy Regulation 2003, mentioned that information should not be disclosed except under authority of law. So the same thing is being taken into consideration. Confidentiality is again of paramount importance. So what is happening with the new insertion in 2021? Name and other particulars of a woman whose pregnancy has been terminated shall not be revealed except to a person authorized by any law for the time being in force. So the details of the patient are not supposed to be shared with anyone. And many times the question arises now how to fill up the form, how to put in the records. So you can give a code or you can give a specific number according to the hospital to that particular patient, but the confidentiality is not to be compromised. So the potential outcome is increase in privacy and confidentiality of abortion seekers, increase demand, but need to safeguard rights and dignity of women and provide respectful, bias-free service, including counseling and contraception. So not only, this act specifies that you give medical termination of pregnancy, terminate the pregnancy, but at the same time, it is very important. In the later, section, we will be coming to know how to counsel the patient, and it is of paramount importance again to tell her regarding contraception, what are the various ways of contraception, and it depends on her which one to choose. Now, termination or abortion is not a means of contraception. Many a times this perception goes into the mind of the woman that if she's not, if at all she conceives, she will go in for repeated abortion. So that should not happen. The health should not be compromised. So for that, whenever the patient comes to you for abortion, at the same time, when you are taking the history, that time also you should counsel her for various methods of contraception. So in the salient features of the new MTP Amendment Act, it prioritizes confidentiality and safety of the woman. Name and other particulars of any woman seeking abortion has to be confidential except to a person authorized in any law for the time being in force. The ground of failure of contraceptive has been extended to women and her partner. Now, we have seen that there was mention of a special and vulnerable category of women eligible for extended gestational period like 20 to 24. So what are these? We'll go into details of these. Then we have been talking about registered medical practitioners should only do the abortion. No one else is authorized to do it. So what do you mean by registered medical practitioner? Then we have talked about medical boards. If the pregnancy is beyond 24 weeks and the patient wants to terminate the pregnancy, then we need to go. Hello? Am I audible?
Yes, Dr. Gurpreet, you are audible. Somebody, please mute yourself.
Okay. Yeah. So the powers and functions of the medical boards, if the pregnancy exceeds beyond 24 weeks also, we can terminate, but we have to seek the permission of the medical board. So who comprises the medical board? So we'll see those in details. So we have made a mention of special category. So in the special category of women who are eligible for the medical termination of pregnancy between 20 to 24 weeks. Here, what are women, which women are to be included in this group? These are first survivors of sexual assault, rape, and incest. Many a times these women are scared, they report late, and that's the reason they go beyond 20 weeks. And they, by the time they make a decision to abort, it is far beyond 24 weeks of gestation. So these are the women who are taken into consideration as a special category. Then women with pregnancy in humanitarian settings, disaster, and/or emergency situation as declared by government. Third is change of marital status during the ongoing pregnancy, like widowhood and divorce. Then women with physical disabilities, like major disabilities as per criteria under the Disability Act. Fifth is mentally ill women, including mental retardation. And sixth is minors. Seventh is the fetal malformation that has substantial risk of being incompatible with life, or if the child was born, it would suffer from such physical or mental abnormalities to be seriously handicapped. So these are the women the law have given them special, that beyond 24 weeks with these problems they can approach for the termination. Second is the norms of a registered medical practitioner. Repeatedly, I've been telling only the registered medical practitioner. So who is the registered medical practitioner? According to old law, as MBBS or more with any. Like these are the criteria if the person is only MBBS. Medical practitioner has assisted in 25 cases of MTP, of which at least 5 done independently in a hospital. Medical practitioner who has completed 6 months of house surgency in obstetrics and gynecology. Medical practitioner who holds a postgraduate degree or diploma in obstetrics and gynec. Medical practitioner who has experience of at least 1 year in practice of obstetrics and gynecology. So this is a person who we consider as a registered medical practitioner who can perform. And now again, the same thing is given below, that up to 20 weeks. We should be very clear in our mind that up to 20 weeks, now we need opinion of only one registered medical practitioner. 20 to 24 weeks, 2 registered medical practitioners' opinion is required. And beyond 24 weeks, we need to take permission from the medical board. Now, under the Amendment Rule 2021, an additional category of provider has been added for termination up to 9 weeks with medical methods. Who is the person who can do this? Up to 9 weeks. Now, a registered medical practitioner with experience in the practice of obstetrics and gynecology at any hospital for 3 months can, prescribe this medical method of abortion. or a person training with performance of 10 cases of MTP by medical method under the supervision of a registered medical practitioner in a hospital established or maintained or a training institute approved for this purpose by the government. So the norms for the registered medical practitioner whose opinion is required for termination of pregnancy at different gestational age till 9 weeks, experience and training requirement for the RMP is first experience of any hospital 3 months. The same thing has been repeated in the practice of obs and gynae, or has independently performed 10 cases of MTP by medical method under supervision of an RMP in a hospital established or maintained or a training institute approved for this purpose by the government. Second is a practitioner who has assisted a RMP in the performance of 25 cases of MTP, of which at least 5 have been done independently in a hospital. A practitioner who holds a postgraduate degree or diploma in obs and gynae. Fourth, a practitioner who has completed 6 months of house surgency in obs and gynae. Fifth is a person who has experience of at any hospital for a period of not less than 1 year in the practice of obs and gynae. So till 9 weeks, only one registered medical practitioner is required. With these criteria, they should meet. And then till 12 weeks, again, only one RMP is required, experience and training the same. There's not much difference. And beyond 12 weeks till 20 weeks, experience and training requirement for the RMP is a practitioner who holds a postgraduate degree or diploma in obs gynae. Second, a practitioner who has completed 6 months of house surgency in obs and gynae. Third is a practitioner who has experience at any hospital for a period of not less than 1 year in the practice of obs and gynae. So here till 20 weeks, we have said only one RMP is required. Now beyond 20 weeks, till 24 weeks, we need opinion of 2 RMPs. The experience they should have or possess is a practitioner who holds a postgraduate degree or diploma in obs and gynae. Second is a practitioner who has completed 6 months of house surgency in obs and gynae. Or third is a practitioner who has experience at any hospital for a period not less than 1 year in the practice of obs and gynae. Now beyond 24 weeks, here is the problem. Many times, this is the question which is asked. Beyond 24 weeks, if we want to terminate, then we can do the termination provided we meet all the criteria. So experience and training requirement of RMP, we need to have 2 RMPs, a practitioner who holds a postgraduate degree or diploma in obs and gynae. Second is a practitioner who has experience at any hospital for a period of not less than 1 year in the practice of obs and gynae. Apart from this, we need to take the opinion of medical board is required for the termination procedure. When advised by the medical board is carried out with all the safety precaution along with appropriate counseling and at an approved place. So all the P's, provider should be approved, place should be registered, and the process should be according to the gestation. So who will comprise the medical board? It should be a gynecologist plus a pediatrician, a radiologist, or a sonologist. If they want additional of other specialists, they can include in the board. So in the once the board is comprised, there is set board, then what are the powers of the medical boards? The powers are to allow or deny. They can allow and they can even deny termination of pregnancy beyond 24 weeks of gestation period only after due consideration and ensuring that the procedure would be safe for the woman at the gestation age and whether the fetal malformation has substantial risk of it being incompatible with life, or if the child when born would suffer from such physical or mental abnormalities to be seriously handicapped. And co-opt other specialists in the board and ask for any additional investigations if required for deciding on the termination of pregnancy. So FOXI with the ministry guidance and the World Health Organization's support as part of the respectful abortion care can operationalize and host medical board information on the website. Now, functions of the medical board: to examine the woman and her reports who would approach for medical termination of pregnancy. Second is to provide the opinion of medical board in Form D with regard to the termination of pregnancy or rejection of request for termination within 3 days of receiving the request for medical termination of pregnancy. Third is to ensure that the termination procedure, when advised by the medical board, is carried out with all safety precautions along with appropriate counseling within 5 days of the receipt of the request for medical termination of pregnancy. So not a lot of time is being wasted here. They have a time frame wherein they have to respond whether they are going to give the permission or they are not going to give the permission for the termination of pregnancy. So that criteria is also there. Then FOXI has an important role to play in ensuring there are functional medical boards in every state, as is stated in the MTP Amendment 2021. Up till now, I've told you there are 178 boards which are already formed. So in India, abortion is legal. Let us make it safe and respectful. Thank you very much. Hello.
Yes, Gurpreet, great. It was a nice presentation by you, and you have covered almost all the points. You are left, but not that important. Can we have opinion of Dr. MC Patel, sir, please?
Many congratulations, Gurpreet. Nicely covered the subject.
Thank you.
Failure of contraception. It is available to now any woman, because previously it was word married woman and her spouse. Now word married woman is changed with any woman, and word spouse is changed by any person. So now it is available, but it should be kept in mind, it is available only up to 20 weeks of pregnancy. So beyond 20 weeks or less than 20 weeks, with opinion of two medical registered medical practitioner, one cannot terminate pregnancy merely on ground of failure of contraception. So it should be kept in mind that it is available up to 20 weeks of pregnancy only.
Thank you, sir.
Yes.
Any comments from Sneha, madam?
No, of course, after MC sir, no comments from my side. Only hearty congratulations to you, Gurpreet.
That's first thing which clicked to my mind is MC Patel sir, Rajamani sir, and your name, madam, for this program. Thank you so much. Thank you.
Yes.
Now we move on to the next talk by Dr. Anjali Vari, madam. She is president of Aurangabad OBGYN Society. Over to you, madam.
Anjali Vare, madam, you are muted. You are not heard.
No, madam, you are not audible.
Yes, not audible.
She is unmuted, but then her audio has got some problem, I think. You need to change your.
It is seen, but she is not audible. Yes.
I think without earphones. Are you using some earphones, headphones? No.
Hello.
Yes.
Audible now?
Yes,
Okay,
yes.
yeah.
Now audible.
Okay.
Welcome.
Okay. Hello. Gurpreet, can you? Okay, now I have got my shared screen. Good evening, everyone. Today, we will see now in this topic about safe abortions, that is updates in technology. Various guidelines have been given by WHO, that is for safe abortions, for techniques and policies. WHO guidelines have changed in 2014, 15, again in 18 and 2019.
Madam, you need to share the screen.
Yes, I have shared screen.
No, it is not seen.
You are not able to see? Okay. Again, I will do.
Madam, open your PPT, minimize.
Yes.
Yeah.
I have opened the PPT. I have. Okay. Now, can you see?
No, madam.
No.
No.
Now?
No,
Are
madam.
you clicking on share screen button, that green icon at the bottom?
Yeah, madam.
Yes.
I have clicked the share screen.
No, it's not happening.
Now? No?
No.
No, still not.
Don't know why.
Anjali madam,
Yes.
you minimize the Zoom meeting first. You minimize
Okay.
the Zoom meeting.
Yeah.
After that, you open your presentation completely.
Just a minute. Now I have opened my presentation completely.
Now you again maximize the Zoom meeting.
Okay. Now I will.
Now you go to the slide share.
Just a minute. Now I will maximize the Zoom meeting.
Now you do the
still
slide share.
No. I am not able to do. Just a minute.
There is one option. Gurpreet, can you show from your end and madam will speak from her end?
Ajay, before that, Anjali madam, you please log out once and log in again.
Okay.
And when
That is
you
enough.
log in,
Now
before
can
that, you keep your presentation ready on the screen.
Just
log in.
Open your
If you
PPT and then you click on the share screen button, that icon.
Yes, madam. I have already opened the PPTs.
This is one option to try.
Open it and minimize. Yes, now. Now we can see it. Yes. Now full screen and share slide.
Just a minute. Now is it?
Yes, now it is seen.
Now can you see?
Yes.
Yes.
I think, but now I should go on slideshow.
Madam, right hand side there is one icon, 68%.
Make it full screen.
Right hand side, 68%. Near that you'll have that slide screen.
Lower border.
Just a minute. I am doing.
Maximize.
Yes.
Right.
Can you see now?
Yes.
Okay, thank you for your help. Now we will see about the safe abortion. Yes, in 2021 Medical Termination Act amendment has been changed, and in this we will see about first pre-abortion care, then abortion care methods, after care and follow-up, including post-abortion contraception and counseling. In the pre-abortion care, we'll see about medical history, physical examination, and laboratory investigations. And then comes the decision making. In pre-abortion assessment, first we have to take detailed history, then general physical examination of the patient, pelvic examination, and laboratory and other investigations. And last is the decision making, depending upon the patient's counseling. Dating of the pregnancy is done usually by clinical history and examination only. Only limitations are, sonography is not must for all cases. Only when there is uterine malformations because of fibroids, multiple gestations are there, and marked uterine retroversion, patient is obese, and if there is any evidence of molar pregnancy, actually that comes in sonography only, and uterus that is smaller than expected, and then only the sonography is indicated. Routine lab tests are not a prerequisite for abortion services, and tests that may be performed as per individual risk factors or according to your physical examination. Pregnancy tests, if pregnancy is not confirmed, then only you should do. Hemoglobin, if you suspect anemia, then blood group and RH typing, if is available should be done. HIV testing and other laboratory tests are indicated according to the medical history of the patient. That is, if you suspect anything, then only you should go for the liver function test and kidney function test. Important is ultrasound is not necessary unless to diagnosis of the pregnancy, or you are suspecting ectopic pregnancy or missed abortion. In pre-abortion counseling, you should ask patient about whether it is she has confirmed the decision of termination of the pregnancy, reason for terminating the pregnancy. Then you should inform patient about safety of the abortion if it is an early abortion. Then importance of a trained provider performing the procedure for safety. Then availability of the various methods of abortion, risk and warning signs associated with the various abortion methods. And without contraception, she can get pregnant as early as 14 days after abortion. It is must that you should inform her that. Then resumption of her normal activities, including sexual activity, and any other follow-up care if needed. In documents, informed written consent is must, and decision to accept the post-abortion contraception. Even if she is not willing for contraception, you should explain her everything. In clinical management, when pregnancy is less than 12 weeks, medical method, that is mifepristone plus misoprostol, then misoprostol only, and vacuum aspiration. And when it is more than 12 weeks, mifepristone and misoprostol only, and dilatation and evacuation. Dilatation and evacuation with sharp curette is not recommended. In clinical management, in first trimester, usually two methods are available: medical method and surgical method, that is manual vacuum aspiration. In medical method, mifepristone and antiprogesterone, which inhibits action of progesterone, it interferes with the continuation of pregnancy. It is first dose of mifepristone is given, which is followed by misoprostol, that is prostaglandin analog. Misoprostol causes cervical softening, uterine contraction, and expulsion of products of conception. On day 1, we are giving mifepristone, that is 200 milligram of mifepristone orally. And if patient is Rh negative, then on the same day, you should give anti-D 50 microgram. On day 3, mifepristone is given. Up to 7 weeks, it is given 400 microgram. You can give it either sublingually, buccally, vaginally, or orally. And from 7 to 9 weeks, 800 of microgram misoprostol should be given. And additional, if needed, analgesics, that is ibuprofen, antiemetics, and should be given. And at the same visit, you should offer contraception to the patient. The follow-up day should be within 15 days. And in that follow-up, you should confirm and ensure the completion of the procedure, then offer contraception, if not already done, because we are telling her about contraception from the day 1. In oral route, pills are swallowed, and it is recommended up to 7 weeks. That is for the first trimester abortion. Side effects of oral route are diarrhea, nausea, fever, and chills. While if you are giving pills buccally, when they are placed between the gums and cheeks and swallowed after 30 minutes, chances of fever and chills are more in that route. When pills are placed under the tongue and swallowed after 30 minutes, that is sublingually, there is increased chances of fever, chills, diarrhea, and vomitings compared to the vaginal route. But it is the fastest route, that is onset of action is fast, and plasma concentration level reaches earlier. While in vaginal route, we are keeping pills in the vaginal fornices, that is the deepest portion of the vagina, and the woman is instructed to lie down for 30 minutes. In this case, you can see the fragments of the pill, and there are lowest side effect by vaginal route. This figure shows you how to place the pills buccally and sublingually. In induced abortion, less than 12 weeks, mifepristone 200 milligram is recommended and misoprostol is 800. In services should be available at the primary care level with referral systems when you are giving medical method of abortion. Additional services may need to be provided to the individual seeking medical abortion, that is counseling and testing for sexually transmitted infections, then abuse support services, psychological or social services, other specialists, health or medical services, then provide iron tablets if patient is anemic, and provide any necessary pain medications, provide emotional support if needed. In follow-up care, routine follow-up is not necessary following an uncomplicated medical abortion using mifepristone and misoprostol, while a follow-up visit 7 to 14 days after the procedure may be offered to provide contraceptive counseling and services, and emotional support or address any medical concern. A routine follow-up visit is recommended only in case of medical abortion using misoprostol alone to assess the success of abortion. In follow-up care, you should assess the woman's recovery, ask for any signs and symptoms of ongoing pregnancy, review any available medical records and referral documents, ask about any symptoms experienced since the procedure, perform a focused physical examination for any complaints, assess women's fertility goal and need for contraceptive services if not provided earlier. In summary, physical examination, confirm eligibility up to 49 days and 7 weeks. Then you should give tablet mifepristone 200 milligram orally, offer anti-D if patient is Rh negative, and tell the woman that return for misoprostol administration after 2 days, contact address and phone numbers of the facility and centers where she can go in case of any emergency. Record her experience of any side effect on the medical management of abortion. 3% of women may expel completely with mifepristone alone, but misoprostol schedule should be completed. What to do? First, give misoprostol 400 micrograms sublingually, buccally, vaginally, and observe for 4 hours. If necessary, give ibuprofen 400 milligram, and contraceptive option should be given to the patient. Tell women that mean period of bleeding will be 8 to 13 days and possible side effects, that is nausea, vomiting, diarrhea, headache, fever, and dizziness. Report in case of excessive bleeding, pain, abdomen, and fever. Report if there is no bleeding 24 hours after misoprostol. Consider giving additional dose of misoprostol. 75% women abort within 4 to 6 hours after misoprostol administration. Pelvic examination should be done to ensure the completeness of abortion. And contraceptive options are, which you can offer are, you can give her hormones, that is oral contraception, then condoms, IUCD, sterilization after 1 menstrual cycle. About immediate return to fertility, report back if there are no periods within 6 weeks of completion of the abortion process. 75% of women abort within 4 to 6 hours, and USG only required if examination does not confirm the completion of the procedure. What are the side effects and complications? Pain. You should not be a judgmental while assessing the pain. If patient is having pain, you should offer her analgesics. Then verbal support should be given, adequate counseling should be done, and if needed, then only ibuprofen should be given. If there is persistent pain with failure to respond to these drugs, then evaluation should be done, and ectopic pregnancy, infection, or incomplete abortion should be ruled out. If patient is having nausea and vomiting, usually it is self-limiting, and reassurance should be done, and if needed, then only antiemetic should be given. Diarrhea is also self-limiting, and for infection, first you confirm by physical examination and start antibiotics. Action for failure or incomplete. If there is a failure of medical method of abortion, then you can offer patient, either you can repeat the dose or vacuum aspiration should be done. And if there is an incomplete, observe unless there is heavy bleeding, If bleeding is resolved and uterus comes to normal size, it means abortion is complete. If heavy bleeding continues, then you can offer her surgical method or repeat misoprostol. If patient is having excessive bleeding, that is bleeding more than her menstrual cycle, if she's soaking 2 pads in 1 hour for 2 consecutive hours, and if bleeding decreases over time, then routine care, that is keep a watch on her vitals and bleeding, and she can go home afterwards. If bleeding does not reduces, then watch vital signs, PV examination should be done. Product of conceptions, if they are in cervical canal, you can do manual evacuation. If woman is stable and bleeding reduces, then again observe. If she is stable, you can send her home. If woman is again having bleeding, then USG should be done. And if there is minimal decidual beads, wait and watch. If POCs and decidual beads are seen and woman is stable, you can repeat the misoprostol 600 microgram. And if his woman is not stable, then vacuum aspiration should be done. And if USG shows continuation of pregnancy, then vacuum aspiration should be done. As the medical method of abortion comes under the MTP Act, documentation is same as for vacuum aspiration procedure. It is mandatory to fill Form C, that is consent form, Form 1, that is RMP opinion, Form 2, that is monthly reporting form, and Form 3, that is admission register for case record. In methods of first trimester abortion, that is a surgical method, MVA or EVA. In vacuum aspiration is recommended technique up to 12 weeks. WHO recommends manual vacuum aspiration as the safest method, and the procedure should not be routinely completed by sharp curettage. Procedure of abortion performed is same regardless of type of vacuum used. Handheld aspirator used to generate vacuum. Aspirator is attached to cannula, that is 4 to 12 mm in diameter. Cannula can be used in multiple settings, including those without electricity. IPAS or easy grip cannula size corresponds with the week of gestation. That is 8 mm cannula corresponds with the 8 weeks, 6 mm with 6 weeks, etc. Here you can see the various parts of the IPAS. In electrical vacuum aspiration, electric pump is used to generate vacuum. It can accommodate cannula of manual vacuum aspiration with the correct size tubings. Previously, we used to use the metal, but now we are using only IPAS cannulas. Cervical priming can be considered for women with pregnancy of any gestational age to prepare the cervix and make it soft and easy to dilate. Recommended methods for cervical preparation are oral mifepristone 200, 24 to 48 hours in advance, then misoprostol 400 administered sublingually 2 to 3 hours prior to the procedure, misoprostol 400 vaginally 3 hours prior, and laminaria 10 6 to 24 hours prior to the procedure. In pain management, it is an important component of quality abortion care, as it reduces pain and anxiety and makes women comfortable. And 2 components of pain management are, one is non-pharmacological and pharmacological, that is use of medication. First is you should provide her psychological support, explaining each step to the woman in advance, what you are going to perform. That is, procedure should be gentle and smooth, encouraging the woman to relax and breathe deeply. In pain management, anxiolytic, that is diazepam or general anesthesia can be given. That is diazepam 10 milligram orally. Duration of action is 4 to 6 hours, and side effects are dizziness and disorientation. In cervical dilatation, lignocaine, that is local anesthetist, or analgesics, that is ibuprofen, can be used. 10 ml of 1% lignocaine is used. And if you then 400 to 800 milligram 1 hour prior to the procedure, misoprostol should be given. And duration of action of lignocaine is 60 to 90 minutes. Side effects are dizziness. In rare cases, seizures, it goes intravenous. And uterine cramping. For uterine cramping, you can give analgesics, that is ibuprofen. that is 400 to 800 milligram 1 hour prior to the procedure. And duration is 4 to 6 hours. Steps of MVA are same as we have seen with the IPAS. First, you should ask the women to empty the bladder, then administer paracervical block under aseptic precautions, dilate the cervix, then insert the cannula, withdraw cannula 1 to 2 centimeters away from the fundus inside the uterine cavity, rotate the cannula in 10 to 2 o'clock position with smooth gentle motion, and release the vacuum button on the aspirator. Signs of emptiness, uterus, that is uterus is empty, are red or pink foam without tissue passing through the cannula, gritty sensation over the surface of the uterus, cervix gripping over the cannula, uterus contracting around the cannula, that is increased uterine cramping. Then after that, you should inspect the tissue to confirm the products of conception. Then proceed with the contraception method such as sterilization, IUCD, if patient has given the consent. Postoperatively, you should monitor her for any complication and provide management as needed. She may leave the facility when she is stable and meet the criteria for the discharge. Ensure that woman has all necessary information and medication prior to leaving the facility. Document all outcomes of the treatment, including any adverse events, in the facility register and client's record card. In aftercare management of abortion complications, that is incomplete abortion, infection, bleeding, or ongoing pregnancy, and provision of contraceptive information and offer contraceptive counseling and method. Assessment of any other sexual and reproductive health needs that may require additional care. No routine follow-up unless meso alone, that is only misoprostol regime is used. This is a new recommendation. In summary, India has made historic progress in improving access to the safe abortion. Not much has changed in technological update in the last decade. As providers, it is up to us to ensure safety and quality, especially in context to the new amended law. Along with safety, we also need to focus on respectful abortion services. Every client, public or private, an opportunity to inform, educate, and equip with proper information on contraception and counseling should be done. Thank you. Gurpreet, I was audible?
Yes, yes, madam. Yes.
I thought I was again on mute.
No, no, madam.
Okay.
It was lucid. Very nice. Can I have, yes, sir.
Again, Anjali madam, it was very comprehensive and up-to-date presentation by you, and very silently told. Very good presentation. Dr. Kiranmai or Sneha madam, are you there, Sneha ma'am?
Yes, yes.
Yes.
Yeah,
I'm
please,
here.
please. Can we have your opinion, please?
Yes, yes. Very well presented, Dr. Anjali. And of course, till now, as I have said, only we were talking about the liberalization and safety. And this is the point of time now where onwards we have to talk about the respectful abortion care. And you have very, very well expressed, apart from the amendments in the Act, what you have expressed, that the privacy and of course her feelings, everything as far as the abortion care is concerned. So that has to be maintained. So abortion, not only safe, but it has to be respectful. That is a very good message you have delivered. And thank you so much. And over to you again, Dr. Gurpreet.
Thank you so much, Dr. Sneha, madam.
Hello, can I ask one question?
Next, we have with us Dr. Kiran.
Dr. Neeraj want to ask something.
Yes, yes.
Yeah.
Yes, yes, sir.
I just want to ask about the medical management of abortion. Can
Yes,
we
sir.
do up to 12 weeks or up to 60 days only?
No, sir, no. It's not like that. We can do after that also. After 9 weeks, we can do.
No, you mentioned about 12 weeks. No? So, if it
Yeah,
is more than 9
nahi,
weeks, then you have to give 800 milligram of misoprostol. So,
Yes, afterwards you have to give, initially you can give 400.
Yeah, for up to 9 weeks.
Afterwards you can give 800.
So
And
it
you
is up
can
to-
do.
we can give up to 12 weeks medical management.
Yeah, yeah.
Okay.
Mainly 7 to 9 weeks, sir, they have mentioned.
No. But in your
Ah.
presentation, it was mentioned that if it is more than 9 weeks, then you can give 800 milligram of misoprostol on day 3. So that's why I'm asking.
Yeah, Neeraj bhai, basically what is the aim
Recommendation
behind this 7 to 9 weeks? 9 weeks is 63 days basically.
Yeah.
That can be given at clinic where the registered MTP center is not there. If the registered MTP center is there, it can be given after also, as Anjali madam said correctly. So if it is given, if it is in registered MTP center, it can be given after also.
But only thing
63
I
days
think
is
that
limit
patient
for
should be admitted.
unregistered center.
And you have to admit the patient for that.
So anyone can give up to 9 weeks.
Yeah,
No need of
Up
your
to
center
9
to be-
weeks, any RMP can be given, but he should be only attached to the
Yes,
medical MTP center, government authorized medical termination center, and he should be in contact with that person who is having that MTP center. That is a law. Means
Basically, he should be in touch with that
Touch with that
center.
center, with emergency
Officially,
facilities.
he should display that such and such center will take care
Yes.
if at all there is any complication or need for further surgical management.
So should I comment?
Yes,
Yes,
sir.
Yes, sir.
Neeraj, a question.
Can you stop
Up
the
to
sharing?
63 days, it can be allowed by medical method, and it was clarified in one of the RTI which happened in 2012. Question was raised up to how much days of pregnancy one can go for medical termination of pregnancy. So it was clarified. So up to 63 days one can. And as mentioned by Dr. Sneha, person
in
who
this
is running only OPD, say for example, only consulting room,
Yes.
no indoor facility, can he or she prescribe RU 486 for termination of pregnancy? Yes.
Yes, sir. Yes,
Yes,
sir.
yes.
He can this.
But he or she should have access to a registered
MTP
center
center. Yes.
where she can manage complication of her patient.
She
Say
can
for
send the
example,
patient
it remain incomplete and ENE or any other method is to be allowed, then she should have access, and certificate of approval from that registered center is to be displayed at place of that person who is running only OPD or only consulting room. So if it is, then it will be allowed. But now one more question, as far as records related to this termination of pregnancy.
Yeah.
Because she has terminated, prescribed RU 486 for termination. So who will issue Form C? Form 1. So Form C, naturally it is consent on part of patient. So whosoever prescribe, she will take signature of patient in Form C. And one more consent, that is we can say it is informed consent. Okay, whenever we are giving medical method, then it is also likely that it may remain incomplete also, or some infection. So whichever the possibilities are there, it is to be explained to the patient, and one more informed consent is to be taken. So two consent, one informed consent separately and one consent in Form C. And Form 1, that is form of opinion, it is to be filled by that person who has prescribed. And those forms, Form C and Form 1, he will send to center from she or he has access to deal with her patient as far as complications are concerned. And that particular center, hospital, who has given access, will give report to CDMO at the end of month, including all these cases happened to that particular center.
But Dr. MC Patel, there is a law where it is mentioned that there are two consent are necessary. Only one Form C is required for the consent.
The form consent to be taken on Form C is very much mandatory,
Yeah.
as far as MTP Act is concerned. Because if you do not take consent in
Yes.
Form C,
Yeah.
it will be considered as a MTP without consent.
Yes.
And you will lose shelter of umbrella of MTP Act, and you may be tried under section 313 of IPC,
Right.
which is dangerous one, because there is a provision of 10 years of imprisonment So how much important of consent to be taken on Form C is. So you cannot afford not to take consent in Form C. Of course, you can take one more consent. It is abundant caution. But Form C consent is very much mandatory.
Sir, but I think that center should keep register, and there
Yes.
that entry should go, and
Yes.
MTP number should be given by that MTP center.
Yes, agreed.
Yeah.
Because there should not be duplication of
No.
record.
No.
So Form C, Form 1, whichever record is to be maintained by primary center, just for a sake of discussion, we say primary center. And secondary center where access is available. So he will give only statistic that in this month I have prescribed RU 486 or medical termination of maternity with 5 patients. So those number of 5 will be included in report of that center. That is secondary center. So there should not be duplication of statistic.
No, sir. What I think is that maintenance of record is also responsibility of second MTP center. That is
Naturally.
That paper
So
should finally go to
primary center will send all those records, that is Form C and Form 1 to that center, and all this record will be preserved by that secondary center.
Yes.
Yeah, and about the age limit, what is the ideal? When can we use the medical method? What after what age? If it is less than 18 years, then what we can do?
So as per MTP, there is no specification.
Okay.
So you can give to any patient.
You can give it to any patient.
Sir, can I just add one thing?
Yes, Kiran,
Neeraj sir asked 9 weeks or 12 weeks. There is one small, sir, good evening. Global recommendations say 9 to 12 weeks also it is allowed by medical method, but Government of India recommends up to 9 weeks.
Up to 63
medical
days.
method.
No,
up to 63 days.
Yeah.
Just I mentioned, just I mentioned in this RTI which happened in 2012, government has specified that pregnancy up to 63 days can be allowed to be terminated by medical method.
Yes, sir. 5 to 12 weeks, there are global recommendations, but Government of India, it is 6.
Yes. So we will have to abide by our government's regular rules.
63 days, that would be safer, I think. Yeah.
Thank you so much, NC Patel sir, Dr. Sneha Bhaiya madam, and Ajay Mane sir. Now we move on to the next topic. We have with us Dr. Kiranmay Devneni madam. She's Professor OBGYN, Government Medical College, Vanapati, University of Health Sciences, Hyderabad, Telangana. Coordinator Foxy Dhira Initiative, Stop Violence Against Women. I'm very delighted to share with all of you that madam has been elected unopposed for the post of Say No to Violence Against Women. This is a new committee that is formed in Foxy. Congratulations to you, madam. And yes, and madam has conducted many programs, trainer for the RAC.
That would be enough. Thank you. We are running late. Yeah.
Yes.
Madam, if madam stops share screen, I can share. I think Anjali madam is still sharing. Dr. Anjali. Thank you. It's really a privilege, and thank you for having me here at Aurangabad, Gurpreet, and congratulate you for this successful, wonderful RAC module, I should say, Foxy WHO, and also a delight to have all the experts here, Patel sir, Mane sir, and also Dr. Sneha and everyone. So without further delay, I would go to the third module, that is the WHO Saver Toolkit. So as Dr. Sneha was telling very clearly that the respectful component of abortion. See, safety is one aspect and the respectful. Am I audible?
Yes, madam.
Okay, my internet connection is little unstable. Okay, so the respectful component of the abortion is more, if not most important now, So this module is the Safe Abortion Values, Evidences, Rights and Respect, which is called as the SAVOR module of WHO. So this is a joint FOXI and WHO initiative, which brings us the technical update as well as the legal update, the new amendments, as well as the respectful component, along with the counseling. So what this module, this particular third module aims to define what we mean by respectful abortion care by WHO standards, and highlight how the norms and stigma that we have, due to our upbringing, due to our culture, due to our, brought up or whatever reasons, how these norms and stigma can affect the services, that is respectful abortion care services, and also provides, if anybody is interested, to go ahead and see the WHO Saver resources which are available online for the respectful abortion care. We know that the momentum has been created. We have one of progressive MTP law as well as the new amendments. We all should be aware that how law has changed. Gurpreet has already told. What we need is dissemination. So, and the OB-GYN support, and what better than FOXI, which has the largest provider base for abortion care. We are 37,000 strong, and we already have mastered the online training because of COVID. And now with this online module, we are reaching everywhere, and we are sharing with everyone the respectful abortion care module with all providers, which is the need of the hour. And also the medical method of abortion uptake has increased, and also early and safe abortions to ensure no PCP and DT conflation. And also now we know that patient safety, respect and quality matters more than ever, and we have a big responsibility and onus on us more than ever. So according to WHO, respectful abortion care refers to care that maintains safety, dignity, confidentiality. You must have heard in the previous presentations how the patient's details are not to be revealed anywhere, and freedom from harm and mistreatment. And also it should enable informed choice and continuous support during and after all types of abortion. So in simpler terms, being respectful, we understand that if we are a provider, we have to treat our patients with dignity, empathy and compassion, regardless of their race, ethnicity, gender, socioeconomic status or reproductive history. I think this is where most of our bias comes with the reproductive history. If the woman is unmarried, or if she is having more and more abortions, or if she's coming for late abortions. So these are the conditions wherein we generally have try to be disrespectful or judgmental. So irrespective of her even reproductive history, we are going to treat her with dignity, empathy and compassion. That is what exactly the respectful care means. And as a patient, you are expected to get all these for you from the provider. So as a health professional, it is our duty to listen and support, and as a patient, it's our right to speak up. So what are norms and stigma? This is a small video which very clearly shows what are norms and stigma, and how these norms and stigma affect our the way we treat our patients. Just go through this short video.
Social norms are the unwritten rules of behavior that are considered acceptable in a group or society. Norms can change according to the environment, situation, and/or culture in which they are found. People's behavior may also change accordingly. What are some examples of social norms? In times of COVID-19, there are new social norms that are considered COVID-19 appropriate behaviors, like wearing a mask, maintaining social distance, and to wash or sanitize our hands regularly. An example of a social norm that we must follow at all times is to not use profanity in conversation, especially formal or official conversations, or when talking to patients, clients. Now let's look at some examples of social norms around gender. Girls wear pink, boys wear blue. This is a gender stereotype. Girls and boys can choose to wear whatever color they like. Color has no gender. Men should be working, strong, and not show emotion. Women should be caring and nurturing and stay at home. Men should work and make money. Women should take care of housework and children. There is no need for women to own or inherit property. Now let's look at a few examples of norms around sexual and reproductive health. Just as norms around gender are smaller aspects of some broader social norms, norms around sexual and reproductive health also trickle down from certain norms around gender. According to the WHO, good sexual and reproductive health implies that people are able to have a satisfying and safe sex life, and that they have the capability to reproduce and the freedom to decide if, when, and how often to do so. A woman should be married before getting pregnant and having children. Adolescent sexuality and premarital sex are unacceptable and immoral. Women are responsible for contraception. Now we see what is stigma. Stigma can be understood as a shared understanding that a person, a quality, or circumstance is somehow morally unacceptable. What are examples of sexual and reproductive health stigma? A shared understanding that sex before marriage is morally wrong and or socially unacceptable. A girl who uses a contraceptive method is promiscuous and will have problems when she decides to get pregnant. A married woman is more deserving of contraceptives than an unmarried woman. A girl who has had an abortion is committing a sin and brings shame to her community. Having an abortion has long-term health effects, and the woman's health will never recover to her pre-abortion state. Women who have had an abortion once would become habitual and avoid using contraception. It is important to understand that norms and stigma are different from laws and policies. For example, an immoral due to stigma, whereas as per law, sex-selective abortion is illegal in India. In this exercise, we explore how social norms and stigma influence access of reproductive health and rights, how people experience SRH stigma, the impact social norms and stigma have on our actions personally and professionally, and the impact they have on the actions of others personally and professionally.
So I think the video was very much self-explanatory. So why we should know the stigma and norms is, why we should educate ourselves about it is that this can be the starting point for disrespect and abuse, because we think the patient is wrong, or because the patient is doing something wrong, our language or our tone towards the patient changes, and this abuse can be as bad as physical abuse, slapping, which doesn't happen now, I know, but it used to happen maybe 10-20 years back, when patients used to complain that they were physically abused by slapping because of various reasons. And then verbal abuse also is common, because of the patient may be screamed at, shouted at, and non-consented care, I mean forcing something on the patient, maybe a family planning method or maybe something. And then sexual abuse, abuse of power, taking advantage, and then the failure to meet professional standards of care, because we have some stigma, we have some idea or judgment that this patient is not worthy of receiving abortion care, or you don't want to give. And then this leads to poor rapport between the women and the providers. And also to add to this, we have health system conditions and constraints. We know that in public health facilities there are always lack of infrastructure, overcrowding, lack of privacy, so which leads to disrespectful care, especially in abortion. And what are the rights of every woman? It's the right of every woman to have freedom from harm and ill treatment, and right to information, protection under laws, either MTP and POXO. So we must be well aware of all these laws, and also PCP and DT, where how they intersect. And then informed consent and refusal also is the right of every woman, and respect for choices and preferences, dignity and quality of care. And then right to timely health care and to the highest attainable level of health, liberty, autonomy, self-determination, and freedom from coercion. These are all the rights of every woman. So the domains of respectful abortion care are again, the cost of repeating, I'll again mention them. Being free from harm and mistreatment, again privacy and confidentiality, dignity, respecting a woman's choice. I mean, her choice, she's capable as an adult, as a human. She is very well capable of making a choice, and she's entitled to her choice. And engaging with effective communication, that is developing soft skills, how you convey to the patients, and how you provide information, and how you seek informed consent, and how you give access to continued, continuous support pre-abortion, throughout abortion, and also post-abortion, and the quality of physical environment and resources, equitable abortion care. That means whatever resources you have, you provide them equitably between all the patients, and competent and motivated providers, and contraception advice throughout, and continuity of care and counseling throughout. These are the 12 domains of respectful abortion care. And now, when we see that how the MTP law has been amended, you can understand that now the responsibility is more on us, because now till 20 weeks it's only one provider who has this responsibility of counseling, contraception, referral, and compassionate care. So instead of 2 RMPs, it is now 1 RMP. So every patient is an opportunity for respect, as providers, owners is on us to educate and also reduce sex selective abortions. And then coming to the 2024 group, that is the vulnerable group, which the government and the MTP amendment has extended. This group, we know that they consists of rape victims, and then widows or divorced women. And this is the particularly special group which needs more compassion and more empathy and more respectful abortion care. This is the group which needs judgment-free and also timely services. So this is another important thing that we have to remember, and also the birth defects where no gestation and board is needed. So the priority is on confidentiality and safety, and also we should remember that respect begets respect. As providers, we have to be mindful of all the socio-cultural aspects. So we have to understand. And coming to this video, I'll skip this video, but I'll tell important points. This is a video which shows guide to how to avoid stigmatizing language. The video says, the key points of this video are, we should never say abort a child. The better word is to say terminate a pregnancy. And also, don't say that POC products of conception is a better word and not fetus. And don't say that, the word female feticide is better to be avoided, and better to use the word as sex selective abortion. And never use the words as parent or would be mother and all, because the embryo or the fetus or products of conception, it carries a moral implication to the pregnant woman. And always use your words carefully. Don't use like get rid of pregnancy or why don't you keep the child. And also don't use terms like repeated abortions and recurrent abortions. It is better to say more than one abortion. And also don't use the words like mother, father. As I have told, pregnant woman is a proper word. And remember always that fetus is not a child. So never use the word as, why are you getting rid of this child? Why don't you want this child? And because now we may have to provide abortions in later gestations. Better use the exact gestation or abortion in second or early third trimester. And these are all the things where we have to remember. Again, you don't use repeat abortions, and you understand what is safe abortion and also what is legal abortion, and then differences between unwanted, unplanned, undesired, all these terminology. So whenever you use certain terms, you have to be very careful how you are using these words. So this is the Saver module. The whole title of this presentation is the Saver module. So I would play this. So this is the WHO training module on which is
No
available.
woman should die due to an unsafe abortion. And when abortion is provided, it should be given in a legal and evidence-based manner with quality, safety, dignity, and respect. WHO has a toolkit on safe abortion values, evidence, and rights, or WHO SEVA, which is a module-based training for doctors, nurses, health providers, program managers, and really anyone to assess our values, address our biases, and learn together to transform our attitudes towards respectful abortion care for anyone who needs it. During the COVID-19 pandemic, we adapted and converted the WHO SEVA toolkit into an innovative, gamified, hybrid version that you can do either in person, online, or as a combination with an expert trainer, or simply by playing one of the standalone games to learn from the comfort of your home. SEVA has 4 modules: Engage, Inform, Explore, and Equip. In the Engage module, participants review recent media stories from the country about gender, unintended pregnancy, the realities of safe and unsafe abortion, and juxtapose these with the global standard definitions. In the Inform module, participants share and discuss background information on SRHR, on safety of legal abortion, contraceptive prevalence, and achieving reproductive rights in the global and regional or local context. In the Explore module, participants will play various games and watch videos relating to gender, safe abortion, preventing unwanted pregnancy, how the stigmatizing attitudes all contribute to stigma from a personal perspective. The Equip module is to promote knowledge of, interest in, and further use of WHO guidelines and tools, with a focus on guidelines and tools relevant to contraception, abortion, and post-abortion care, towards the many steps needed for achieving the Sustainable Development Goals, also known as SDGs, building resilient health systems for universal health coverage, or UHC, leaving no one behind. We must remember quality and dignity of care matter as much as saving lives. SEVA is our small step towards SDGs, starting with ensuring safe abortion is provided with values, evidence, and rights or respect.
So that's about the SEVA toolkit. Anyone who is interested definitely can go and try this. These are the games like Cross the Line and Personal Compass, and you can get a lot of information and new developments by means of these games and all these toolkits. So when we come to the end, we know that from 1970s, before 1970s, it was our priority was unsafe abortions and how to make safe abortions. I think by 2000, we have more or less achieved the safe abortion, and now 2020, it is the respectful abortion. So the stress or the importance is on providing respectful abortion care. So there are 2 recap questions. I would request all of you to just put in the chat box the answers as we go through the just kind of a revision. So according to WHO, restricting access reduces the number of unsafe abortions. Just answer this. Yeah. No. False. Yeah. I think we can have few more answers so that we can be, yeah, false, false, false. Yeah, I think we have all the right answers here. Let me go through the. Yeah, it is false. So because restricting access never reduces the number of unsafe abortions, actually it increases the number of unsafe abortions. And when we consider the abortion safe, these are the only criteria: the methods, the person, and the place. So that is the only criteria we have to see. So restricting access does not reduce the number of unsafe abortions. Thank you for your answers. Now this is another question. She is a 30-year-old woman who is recently widowed, and she wants to get an abortion at 22 weeks. Now you can see that she is a widow, that is a vulnerable group, and the gestational age is 22 weeks, that is above 20 weeks. So now this comes under the new amendment. As a provider, is it your responsibility to tell her to continue this pregnancy? Yes or no? So, no. So many. Neeraj sir has said yes. Okay, let's go to the answers. So, it is no, actually, because again, here comes the component of woman's choice, informed choice, and she's a vulnerable group, and it fits into that 20 to 24 weeks. It is not our place to tell her that she has to continue this pregnancy.
Yeah, the change of marital status, what
Yes,
we have
ma'am.
talked
Not
about.
only, yeah, true. Yes. So it is not our responsibility. It is for her. We can tell her all the methods, risks, and everything, but it is she who takes the decision. Only we have to remember, because it is 20 to 24 weeks, we have to take the 2 RMP opinions. That is it. That is the important thing about the law. So now in India, abortion is legal. Let us make it safe and respectful. So that is the Samarth initiative, safe abortion made available respectfully throughout health systems, and Samarth Bharat, Sampurna Bharat. So thank you for a patient hearing. I'll stop share and I'll go to the next presentation. Gurpreet, shall I?
Yes, madam.
Yeah. So the fourth and final module is the counseling. Again, very important component. So we have had technical component, we have had the new amendments, that is the legal component, and then the respectful component, and comes the last but not the least is the counseling, because without counseling we are not, and that is for family planning, we are not going to, give the comprehensive care. So family planning counseling always should go hand in hand with abortion care, that is the respectful abortion care, and also a few points on how can we leverage the technology for referrals and online consultations. So what is counseling? It's a structured interaction. It is it is two ways, where the person voluntarily receives support and guidance from a trained person, that is, for example, the healthcare provider, in an environment that is conducive to open sharing of thoughts, feelings, and perceptions. It is not like one-way communication, that is the healthcare provider is telling and the client or the patient is pregnant woman is listening. So that is what is counseling. So what is the importance of pre and post abortion counseling? As I have told, it should be an integral part of abortion services, and it is as important as the procedure that you are doing. And because women may need help in decision making, that is what is about informed consent, and wherever needed, always involve the spouse, because these days a lot of questions about whether spouse consent to be taken for sterilization, for abortion. Actually, by law it is not required, but there are some social constraints. So that is the reason why wherever needed, the spouse should be counseled and informed. So what is the critical role of this pre-procedure counseling before going for abortion? There's a big need for this counseling, because this part helps the woman to decide about termination of pregnancy, because your counseling may help her to take a decision whether to go for termination or not, and it will help the woman to choose the method of termination, whether medical, surgical, or anything else, and then ensures the delivery of complete information about the procedure. And also your counseling helps the woman to adopt a contraceptive method, which is, I think, very, very important. Then the procedure, again, we keep on repeating this because it's so very important, that is privacy and confidentiality. Again, being non-judgmental and sensitive to establish rapport, use simple language, not jargon and all, to allow the woman to clarify all her doubts. And now if she has made up her mind for termination of pregnancy, now assess her for the procedure. So, and what about the family planning counseling? Why are we clubbing this family planning counseling with abortion? There are these four things. That is, one is very quick return of fertility. And we need also to keep a 6 months gap if she goes for next pregnancy, and the health benefits and better future pregnancy outcomes. And most importantly, this is an opportune time for contraceptive acceptance. And we know that 90% of abortion related maternal mortality can be prevented by ensuring contraception. So contraception is very, very important. But only thing that I want to stress upon is we cannot force upon contraception. We cannot push a woman to accept contraception if she is not willing. So even if she is not willing, that is the most important point to understand. If the woman is not willing for any contraceptive method, do not refuse MTP. Do not refuse MTP. You should try and counsel her after the procedure. Now, if she's not willing, you have to counsel her during the follow-up in a week's time and counsel. So the only way you are going to convince her is by continued counseling, not by forcing or taking the decision on behalf of the patient. So when do you start this counseling? It is at the first visit or consultation when she comes for the abortion care, except if there is any grief or management, like they are suffering from grief because of the abortion or maybe a late trimester abortion, then you don't force this counseling in the first visit itself. You have to delay it. Now, what to counsel? As I have told, return of fertility, you can tell the patient that her fertility may return as quickly as 10 days to 4 weeks, and help her and tell her with all the choices. Once she picks up a choice, you can go for the method specific counseling. Like if she chooses injectable, then you can counsel regarding that method, or IUCD, you can regard that method, or even OC pills. So method specific counseling, and also counsel them about high risk behavior wherever it is applicable. Now, what is the suitability for accepting contraception? What are the general guiding rules? Is that we all know that the abortion process is complete before any contraception is advised or applied, and there should not be any existing infection, no injury to the genital organs, and rule out the chance of fresh pregnancy. These 4 things are very important. And also after the procedure, you counsel her regarding the precautions and care needed for the post-abortion period. And then now, if you have not counseled her regarding contraception, or if she has not accepted for contraception in your pre-abortion counseling, now is the time for opportunity to counsel for post-abortion contraception. And also reinforce the need for continuing the use of contraceptive method chosen. And again, this has to be done in the principles of privacy, confidentiality. You have to continue, you have to reassure, and you have to repeat. So this is a cycle. Continue to ensure privacy, confidentiality, reassure in case of any problems, and repeat the information about the post-procedure care and danger signs. So now if she has come to you in the post-abortion family planning counseling, now if she has already opted in during the contraceptive abortion method, during the procedure or immediately after the procedure, you appreciate and give her immediate care if it is IUCD or MPA, and give her ongoing care if it is, for example, oral pills. Have a follow-up protocol and cards and continuity. And if she is undecided, then you again have to counsel, allay her anxiety, again stress upon the immediate adoption, why it should be done, and extended period of adoption, involve the spouse, do the couple counseling, and also finally educate them about easy pills also. Now, what are the methods which we can give when immediately after abortion? First is the safest and simplest is the condom, the mechanical method. After abortion, first trimester or second trimester, they can be used as soon as sexual activities resume. And we know the benefits of condoms, especially against STIs and HIV. And also it is one of those methods where men take the responsibility of contraception. Now coming to the IUCD, the long-acting LARC, which is actually we are moving away from the permanent methods towards the long-acting methods. This has got almost 10 years of duration where the woman is protected. So if it is after first trimester, it is inserted immediately or up to 12 days after confirmation of a completed abortion if it is the surgical method. These are from the Government of India guidelines. So if it is a surgical method, if it is a medical method, this IUCD has to be inserted around day 15 of the process, and provided the complete products of conception or expulsion is confirmed and other things are ruled out. If it is second trimester, it can be inserted immediately again or up to 12 days after the procedure is complete and contraindications are ruled out. Only thing is, as I have told, it is 5 to 10 years of long-term contraception. And who can provide this? It can be provided by trained doctors, that is MBBS and above. And if it is after first trimester surgical abortions, ANMs and nurses after first trimester surgical abortions, and by trained doctors only after medical method of abortion. And for second trimester, we should have PPIUCD trained doctors. Though these doctors have to be trained specifically in PPIUCD method to insert after second trimester abortions. We know the benefits, I'll not go into it. Then coming to the hormonal contraception COCs, again after first trimester, remember 1 week, immediately or up to 7 days after abortion using the surgical method. With the medical method, you have to remember day 3, that is a dose of misoprostol, or within day 15 of the process of confirmation of completed abortion. This is how after first trimester. After second trimester, either immediately or up to 7 days after abortion. We know the benefits of COCs. We should maybe stress upon the non-contraceptive benefits about endometrial and ovarian carcinoma and the benign breast disease. And also we should see if the woman is lactating or breastfeeding, and avoid if it is less than 6 months. Then this is one method which I am really fond of and which has found great popularity during the COVID, the medroxyprogesterone acetate MPA injection. In the government of India, the program is called as Antara program, and the supply is there everywhere now, free of cost. Now this method, the most important advantage is the woman here can choose this without informing anyone. I mean, the consent of spouse or mother-in-law, or even telling them is not necessary. She just comes and takes an injection every 3 months and goes. And many women like this. And also, it is one of the best methods in the postpartum period, because one of the issues with MPA is irregular cycles. So in the postpartum period, as such, the periods are irregular and lactational amenorrhea is there. So it doesn't really bother the woman much, and also it doesn't have any effect on the quality and quantity of breast milk. So any postpartum woman, this I think is one of the most ideal methods. So when do we give this? Again, first trimester, just like COCs, up to 7 days after abortion using surgical method. Again, medical method, it is day 3. And second trimester within 7 days of abortion. And it is very highly effective. Its effectiveness matches almost the IUCD. Then coming to the female sterilization, permanent method, it can be done concurrently if the woman is, doesn't have a severe blood loss or any infection. That is, if it is first trimester, you can do either mini lap or laparoscopic sterilization. But with medical method, you better do it only after the first menstrual cycle. Whereas second trimester, after second trimester, it is only mini lap sterilization which can be performed either concurrently or within 7 days of an abortion. Laparoscopic sterilization is not recommended. So it is a permanent method. Before offering this, or before the woman chooses this, especially after immediately after childbirth, so I would suggest you tell her about the other LARC methods also, and because it is permanent and it is difficult to reverse. And vasectomy, it is safe, simple, and it is again the man or the male has the onus of taking it forward, but it is used very, very less in our country, as you all know. Again, to summarize contraceptive methods, so COCs with medical method of abortion, COC is day 3, injectable again on day 3, centroma on day 3, IUCD up to 15 days. Again, COC, this is up to 7 days, injectable up to 7 days, centroman up to 7 days, IUCD again till 12 days, and tubal ligation. So just a summary of what I have told before. And coming to finally to the SRH services and the role of teleconsultation and other technology, we know that COVID has really kind of revolutionized this teleconsultation, telecounseling, teleguidance, telereference, and telelinkage. We have to make maximum utilization of this technology, especially in family planning counseling, and also for pre and post abortal counseling and follow-up care. And there are a lot of websites and social media like Ask Tanu, which we all know. and websites like Hamdo, infographics, helplines, and there are patient education platforms offered by all the global institutes and our own Ministry of Health and Family Welfare and RCOG. Kindly do go through this. So what is the SWOT of teleconsultation? The strength is, as you have told, we could reach our patients through even during the COVID era and spread awareness. And the weakness is we lack that face-to-face and the demonstration part of it. The opportunity is you can easily offer privacy and comfort and cost saving, and you can cut down on the number of visits. And threat is sometimes there can be a misdiagnosis and missed opportunity. So I also think of hybrid services, especially for when you are offering medical method. Medical method, you cannot do it completely online. You need to have, instead of 3 visits, at least 1 visit for signing Form C and also giving medication. So you can do the assessment like confirmed diagnosis. You can take care of the contraceptive needs. You can take care of the counseling by the video conference or Zoom, and you can do the follow-ups very easily by online method. So to conclude, finally, the key messages is this module emphasizes the need for the post-abortal family planning, and please bring the couple on board and strive for 100% coverage, either starting from pre-abortion to even follow-up. Capitalize on the basket. A lot of choices are there and their applicability in the post-abortal period, as you have seen which method when to offer, and use technology as far as possible. Look for its entry in the CAC, that is Comprehensive Abortion Care Services. And then adolescent reproductive health needs, which can be done both by online and offline. So thank you for a patient listening, and any doubts or any queries, I think would be happy to answer. Thank you.
Yes, great talks by Dr. Kiran ma'am, as usual. Both were very nice and explanatory. I think there would not be any question from anybody because you have explained it in a very nice way, basically. So congratulations, and congratulations to you for your election results. Rather,
all your support.
Yes, great. Congratulations. Over to you, Gurpreet.
Yes, sir. Thank you so much, madam. That was very lucid and enlightening talk given by you, and it will benefit all the delegates who have logged in today. Thank you so much. And with that, I would like to also congratulate you on becoming the chairperson. Say no to violence against women. And you have been working a lot since last 2 years on that. So congratulations to you, madam.
Thank you, Gurpreet.
Yes. And with that, I would like to give away the vote of thanks. I would like to thank Dr. MC Patel, sir, Dr. Sneha Bhuya, madam, Dr. Ajay Mane, sir, and the speakers for today, Dr. Anjali Vare, madam, Dr. Kiranmay, madam. She has been covering 2 topics, major topics on today's respectful abortion care. And with that, I would also like to thank main important person, that is Foxy President Dr. Shanta Kumari, madam, for initiating such a informative, webinar on respectful abortion care. Everyone should be knowing the new law and how it is to be used for taking into consideration your own and the patient's safety. And with that, I would like to also thank Dr. Ajay Bharadwaj, sir. He has been very instrumental in getting us all the support, back-end support, and most importantly, all the delegates who have logged in. We had almost 100 delegates today for this webinar, and thank you so much. Thank you, everyone. Thank you. Thank you, MC Patel, sir, once again.
Thank you. Welcome.
Madam, I posted the post section feedback in the chat box, madam.
Gurpreet, please tell about the post test link, which is
yes. When you click the leave button, there will be one pop-up, and you have to fill the post test. Only then you'll be getting the certificates and the feedback. And there is also a link given in the chat box which you have to fill, and then only leave the meeting. Otherwise, certificates.
Either they can click the link in the chat box, or they can do after leaving, which by clicking the continue button.
Yes. There is a link in the chat box for everyone. You can just click the link, give the feedback and the post test, and leave the meeting. Thank you so much. Thank you.